Test.
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 Test, test. 1, 2, 3. Test. 1, 2, 3. Test. Test. We live?
Hello, everyone. Thank you for coming. I see there's a big crowd today, and also people that were online. I just want to welcome to you something that's new and different that we would like to introduce to the region. With our friends at the Alcira Group and Robotic Group and Can-Am Scientific, we want to show you something that's wonderful. There's a big seminar happening today, so I won't take up too much of the time. I'll let Alex Gonzalez step in and let him do his thing.
Thank you and good morning. Thank you to our local partners, Can-Am Scientific and Portica Trading, for hosting Dr. Carlos Garcia, Professor Mark Emberton, and myself. My name is Alex Gonzalez. I am Chief Commercialization Officer for Sonoblate, the makers of the Sonoblate HIFU device. I always start off with this question as to what legacy we're going to leave for men's health care in our region. Because we're at this inflection point where we now have a technology that is substantially changing the lives of men. It has gone through an evolution. It is not new. And I'm hoping that today, having Dr. Garcia speak about his work with BPH, having Professor Emberton speak about his long-standing work in the use with prostate cancer, you will agree that together we can really change the lives of men for the better. The current landscape, I won't go over the numbers. You know the numbers better than I do with respect to the technology, the incidence of BPH, the incidence of prostate cancer. We know that with better detection, we're finding more disease with respect to adenocarcinoma. With respect to BPH, we know that it has a direct link to obesity, and we know that there is a significant amount of obesity in the Middle East, which is just making that problem worse and worse. Just the basic HIFU physics. I always tell people it's one of the most basic concepts. If you go back as a child who didn't play with a magnifying glass, and where you put your hand right in front of that magnifying glass, before the energy was focused, you really didn't feel any type of thermal impact. But as we created that thermal cone of energy, and we focused that energy, in this instance, the sun, over a pinpoint area, we could feel a significant multifold increase in that thermal energy, and we could actually burn that leaf. HIFU is just the same thing. That high intensity focused ultrasound that we're using to image simultaneously is focused in over an area of millimetric precision that we've pre-programmed. So you get an ablation, a robotic ablation, in a very discrete, very precise pinpoint area. The HIFU system, as you see it here on the stage, is made up of the main computer console that is the nerve center of the system. That would be operated by the physician. A chilling unit that helps circulate chilled water through the rectum to protect the rectum from any thermal injury. The patient is in a lithotomy supine position. The system has an integrated millimetric stepper that helps make the fine adjustments right as that transrectal probe is inserted. And you'll see here a anatomic fly-through. You'll see the lesion being targeted, represented in red. We will scan through the prostate. We will identify the lesion that we would like treated, and then we will have the software recommend a margin that can be adjusted millimetrically to the physician's choosing. The advantage of the Sonoblade system, as you'll see throughout this animation, is that the physician has complete control every single time they fire into the prostate. So we can truly have a customized treatment. Now, the other advantage of this robotic system is that you can integrate your MRI data into the procedure as well. So you've got all of that information. We've got the diagnostic information that we've received from the MRI. We've got the biopsy information. We've got the software helping guide the procedure and recommending the treatment parameters. And we've got multiple imaging views so that you can see the prostate in transverse, sagittal, coronal, and even a three-dimensional rendering. Now, a unique feature in the Sonoblade technology is that you've got this constant feedback. Every single lesion that is deposited into the prostate provides you real-time feedback through our tissue change monitoring software. So for the first time really in an ablation technology, you're getting shot-by-shot feedback, and if you didn't deposit enough energy, it's going to paint it a certain color, and the software hit that energy again if you do. Here's just another illustration of the precision of the technology as we target just at the water line. So we're able to target that focal point right at the water line. As you can see, there's no disturbance between the transducer and the water level, but we're able to achieve that vaporization right at the interface of the water on the air. That's how precise we can get with this system. So as we were discussing right before we went live, we're really not looking for Sonoblade to replace anything. We're looking for Sonoblade to really be an additive complement to what you're already using, especially for those patients that are somewhere between that active surveillance state that we shouldn't be treating with anything, but yet are not at the level to where we need this radical intervention. We know how devastating the side effects can be. We know that patients would rather have a quality of life and a lot of times not treat their disease. So this offering fits right in the middle. This very targeted, very discreet, very low toxicity of treatment that leaves your options open for anything else. You can still treat this patient in the event of recurrence with either another round of a HIFU. You can treat them with radiation. You can treat them with radical surgery. So the approach is, let's start off with one of the most precise, less invasive, less toxic options for so many of these people that are somewhere between watchful waiting and radical candidates. So why focal therapy? I'll have Professor Mark Emberton, who will be coming up next, really expand on this. But we've seen that evidence shows that patients don't want the side effects from a medical treatment and would even trade years of life in exchange for preservation or retention of continence and erectile function. Evidence indicates that usually that aggressive clone originates from that one lesion that we call the index lesion, such that if left untreated, it can really lead to a more metastatic state. Those secondary low-grade lesions are rarely lethal and likely to metastasize and may not really acquire active treatment. But again, we'll leave some of these points to be further discussed by Professor Emberton. And at the end of the day, we really asked ourselves one question as we were developing more and more of this focal approach and comparing it to other disease states. why not treat prostate disease if we've treated it as we have treated other diseases in the past? One great example is breast cancer treatment today, where we incorporate imaging, we incorporate precision-guided biopsy, we incorporate a less invasive, less toxic approach to that disease, and we know that this approach exists for thyroid, lung, and brain. So what we're trying to get to here is more of an evolution to a very precision-guided, discrete treatment. The unique aspect of a focal therapy like Sonoblate is that it allows us to integrate the imaging. It allows us to ablate precisely. It allows us to analyze every single time we treat, and it allows us to really customize this procedure, whether you're doing a true focal, a hemi-ablation. We really don't advocate whole gland treatments for these patients, but the graphic here just illustrates how customized the treatment can really be. Now the biggest advantage is that you can incorporate image fusion into your planning. This here just a short video of a session in place. You will see transverse and sagittal images in real time, and then you will see transverse and sagittal images as a reference, because there is a constant pixel by pixel comparison, so that if you have any patient movement, any changes in the rectum, any swelling in the prostate, the software is helping you monitor the treatment in real time. You're constantly getting feedback for the amount of dosing shot by shot. We will have an illustration and a simulation up here on stage, but I did want you to see a treatment taking place in real time. Tissue change monitoring software, which you see on the bottom right-hand corner, giving the physician a shot-by-shot feedback. You will see the rectum being identified by the software as well to achieve maximum protection for the rectum. The tip of the Sonoblade is constantly measuring the temperature and giving you warning signs in the event that the rectum is either too close to the target, or if the temperature is increasing. And at the end of the day, what can we achieve? Not to steal Dr. Garcia or Professor Emberton's thunder, but this is a slide that actually I've been using from Professor Emberton's team. You can see there a very discrete, very well delineated focal ablation zone confirmed post-MRI. A patient there that has been treated with a hemi-ablation approach, very impressive precision, confirmed there by MRI as well. And there was a discussion earlier, right before we went live, as to how this is not a new approach. HIFU's been around for a very long time. Yes, in a different format, in a whole gland approach, but even the current focal therapy approach has been really around for more than 10 years. And we'll look closer at the data in the following presentations. So just for my part, in summary, from a patient's perspective, we're able to give them good cancer control via precise treatment. They're in an outpatient setting for a couple of hours. It takes 1 to 2 hours for them to really recover. They typically come in the morning. They're typically back home that afternoon. Most patients really achieving a normal lifestyle within a day or two. Low side effect profile compared to some of the more radical treatments, and best of all, it's repeatable if necessary. So you achieve kind of what we all want out of us as a medical device manufacturer, you as a physician, a very happy patient with good outcomes. We're in over 50 countries now, over 40,000 patients treated, and I hope you'll find Dr. Garcia's approach to benign prostatic hyperplasia and the discussion that Professor Mark Emberton will have for us in the next few minutes very interesting. And I'll finish off with the slide I started off with as to what legacy are we going to to leave for our patients? What legacy are we going to create in the region? Because we now have access to the technology, you now have local representation, you have the support from institutions such as Professor Mark Emberton's that will be here to train and to mentor and to guide with their good practices and protocols. So at this point, I think we just really need to act now. So I'll leave you with Dr. Carlos Garcia, who's getting queued up. Dr. Carlos Garcia is not able to join us live here from Dubai, but he's joining us from his home in Mexico. Dr. Carlos Garcia has been an advocate for focal therapies and precision-guided technology for many years now. He has over a 17-year experience with the different iterations of the Sonoblate, and he's currently has a very interesting revival of sorts using the Sonoblate technology back to its origins for BPH, and he's got a pilot study and a very novel approach to using that for BPH. So we'll queue up Dr. Garcia. I thank you for your time, and thank you again for our wonderful hosts for allowing us to be here in Dubai.
¿Listo? Okay. Well, it's an honor to me to participate in this meeting. Unfortunately, not in person, but well, some miles away. But I want to share my experience with using Sonoblate HIFU, specifically in BPH. I want to start telling you that my original experience was with benign prostatic hyperplasia because of the patients that I have. I'm working in a private practice, and the main patients that I have were mainly originally patients with BPH. My original training was trying to understand the usage of this technology, and this was about 15 years ago. So I want to share this experience with you and some new changes that we're trying to use with this same system. Eh, Originally, until now, we're having some selection criteria with using this system. Uh, Same as with all the technologies, patients that are suffering of the uh, problems with lower urinary tract symptoms, patients more than 45 years of age, uh, we're considering patients with an scoring of the International Prostate Scoring System 13 or greater, QMX, you're using their uroflowmetry between 5 and 15 milliliters of per second. And this is very important because we have a limitation with the system. And I have to be honest, the equipment has a height limitation of 4 centimeters, specifically for prostate enlargements, the BPH. We are considering 4.5 centimeters of anteroposterior diameter as the limit. The width and the length is not a problem because we can accommodate the equipment, so we can achieve treatments close to the 60 cubic centimeters. But as you're going to see in this pilot treatments that we are study that we are doing, we're trying to be below 50 cubic centimeters. There are some exclusion criteria. Although we can treat patients with a chronic or acute urinary retention, there's a delay in the moment of spontaneous urination. So we're considering to have a good outcomes. Postvoidal residual less than 150 milliliters. As a general rule, if PSA is more than 4 nanograms per deciliter, we have to discard the risk of prostate cancer. I'm talking of BPH exclusively. In calcifications that produce acoustic shadowing are not the best or the ideal candidates for this kind of treatment, because calcification will cause some issues with the sound passage. So we are not considering that they are good candidates. So we are excluding them. Our technique, our preparation protocol is the previous day for the treatment is a liquid diet. This is very important because we try to clean the bowel, not to have any stool as possible, hydrate the patient. We're using polyethylene glycol, well, in Mexico it's called Nuritheli, 2 liters as preparation, or in the past we used enemas, but recently we're using more the polyethylene glycol, and this is working very, very well. Cleaning perfectly well the bowel. The intention is not to have stools so that can interfere with the ultrasound during the treatment. And fasting starting midnight. That's the main preparation. As our clinic is an outpatient, and we have only private patients, considering some economical issues more than the technology or the technique by itself. We're using anesthesias, mainly a combination, epidural and IV sedation, mainly with propofol, to keep the patient calm and without movements that can interfere with the treatment and the location and good viewing of the prostate. But of course, general anesthesia can be used without trouble. But this is only our technology or methodology to treat the patient. Originally, we used the in our clinic, the classical approach is mainly the thermal ablation. This is achieved using continuous shots that will cause an increase of energy, an increase of heating in the area that we're treating, and this will cause the damage or the destruction of the tissue, specifically the way we include all the tissue in the prostate, and that was the original way we treated it. At the beginning, we included the urethra as part of the treatment. We had a good number of cases, and the intention was using the ultrasound to locate the adenoma, to treat all including the urethra. This is a classical screenshot of the equipment, and we can see in the lower two images the images that are the base for the treatment. And we can see where's the urethra in the sagittal, in the axial views. And originally we treated all the tissue, including the urethra. This is another example where we treated another patient, and the urethra was included. We have the reference image in the lower view, and the urethra was included. What we saw in these cases was that the sloughing tissue and the time of recovery for starting to urinate was quite long. But this was the original experience using the system, including, as you can see in the axial view, that we treated the urethra, and as when we do a tour, the timing for recovery was a little longer than expected. We changed the methodology, and we tried to spare the urethra, preserving it. And you can see in this, these are very, very old screenshots, 2004, and we tried to preserve bladder neck and the rest of the urethra. The advantage with this system is that we can customize the shots that we're going to use, or the areas that we're going to treat. In this case, we selected part of the bladder neck, leaving or preserving a good amount of the bladder neck, and as you can see in this screenshot, the urethra was totally preserved. There's an advantage with the system. We can leave the catheter, and the shots that are given in front of the catheter are not damaging at all the plastic, the material of the catheter. And we can destroy the tissue without interference. So in this case, this was one of the first cases. We preserved the urethra. We treated all the tissue around with constant, continuous shots, achieving a good destruction of tissue. Recently, we had an intention of changing the methodology, using more than the thermal ablation, the cavitational ablation. This means the capacity of the ultrasound to produce this feature or this mechanism of destruction, and we changed the kind of shots. Instead of using a constant and continuous shots, we designed an on and off shots, and well, this is just a name, but we use this name of chessboard or checkerboard technique. The planning is using the same system is very simple. We have the ability or the capacity to see perfectly well the benign enlargement and the catheter in the screen. So we can preserve the urethra and use an on and off technique to destroy the tissue. The intention is to increase the energy on each of the shots and destroy the tissue intermediate to it, preserving the urethra. Strictly a kind of interstitial treatment. This is a coronal view where we can see where is the urethra, and all the treatment is exclusively in the benign enlargement. Same happens, well, I'm gonna go back. This is in the anterior aspect of the enlargement. And this is in the posterior aspect of the enlargement. You can see that we don't treat the peripheral zone. I'm talking of just BPH, not cancer. So the possibility of just treating the enlargement is very, very simple, as we have a very, very acute and clear image of the enlargement. We leave always the catheter so we can locate the urethra and we can save it. These were the first cases. I'm going to show you the number of cases that we have until now. This is a pilot study. But we have noticed a very, very good and interesting progress in the evolution after the treatment. In the sagittal view, you can see the catheter and the position of the shots. It's not necessary to be so aggressive with the urethra, and anyway, we can destroy the tissue without causing any problem. The neurovascular bundles are very far from the area that we're treating. We're locating the end of the treatment, as I will show you in a moment, close to the apex, but no strictly close to the sphincter. So the continence is preserved, the rectal function is preserved, and even ejaculation is preserved. You can see the urethra totally preserved, totally respected. Originally, we treated 3 cases that in which we included the urethra, the partial treatment. And the position was exactly the same, but we included the urethra. In this case, you can see that the location, the topography of the urethra was included in the way of the treatment. You can see that we have shots on and off, and we try to understand how this behaves. This is an anterior view, and you can see, I'm going to show you the way the system shoots and how we have the capacity to see that the tissue was destroyed because of the TCM, the tissue change monitoring, that is part of the system. We have three colorimetric views. One is the orange, if we have a very good amount of energy, a yellow that is suboptimal but good enough to understand that the tissue was destroyed, and green that is not enough to consider the damage of the tissue. In this case, we have all the shots as orange, and we have in the axial view 3, 4 areas treated with orange views. The posterior was, again, using the same system, but we had a difference. We were trying to achieve a cavitation. The cavitation is easily seen with the ultrasound as a widening of the tissue. We use the term corn pop because of the change of a color of being a dark gray, sorry, to a bright area. In this case, we have a cavitation and a minor cavitation in this case, not as important as this one, but strictly we had some, not the expected number of cavitations originally, but enough to consider that all this tissue was destroyed. This is a visual way to know that the tissue was destroyed, more effective than just the colorimetric system. You can see this one is a yellow color. That means that we're a little suboptimal, but enough to consider that the energy achieved in this area was enough to kill the system, the tissue. Again, in another line of treatment, you can see cavitation, although the rest had no changes besides the colorimetric. We did some changes considering energies and considering the usage of the two sides of the key equipment, the 4 centimeters height and the 3 centimeters. And the intention was to achieve to decrease the cavitation threshold and increase the possibility of having more cavitation than originally. In the anterior zone, you can see that the urethra was preserved and the same energy was achieved. Oranges and yellows enough to kill the tissue. But you can see at this moment in the posterior. One detail that we can preserve with the system is that the presence of the veromontanum in the ultrasound that is very, very easily seen, and considering the recommendations to preserve the ejaculation is very easily achieved. We treated some of our patients that had ejaculation and good sexual activity, and we preserved the ejaculation. So the treatment was done immediately above the area where the veromontanum was located without damaging this function. And the most important and the most interesting part of this was this amount of cavitation. We calculated, although this was a little below the area of treatment, but we have good amount of cavitation, as you can see in all. This is just a couple of examples, but you can see we calculated around 80% of cavitations in all these treatments. So the advantage of having this amount of cavitation is that this tissue is no doubt that is destroyed, totally destroyed. And the intermediate tissue is destroyed as well. Besides that, we don't touch it, but you can see over here that we have a cavitation in between the two shots, and that's enough to consider that we're destroying, as you can see in the axial, in 2 lines, we have the intermediate tissue cavitated, so that tissue is vaporized, killed totally. In this follow-up that we used, you can see that we have this cystoscopy in a couple of patients. I'm showing you. The bladder neck was respected, and you can see the area treated that we have this cavity where the adenoma was located. So this is 3 months after the treatment, and there's no doubt that the tissue is totally destroyed and healed. The sphincter is untouched. Some minor scars, but patients are urinating very well. Our patients, we treated until now in this pilot study 19 cases. Ages are between 57 to 80 years of age, with an average of 67. The IPSS as preoperative, considering 13 or more, where the average 21.94, and after 3 months after the treatment, there was an improvement and a decrease of the scoring to 11. The prostate volume originally was in an average of 39.42 between 28 and 50. And 3 months later, we checked 12 cases with a decrease of the volume to about 23 cubic centimeters. The quality of life in the originally was not good, because almost all the patients were suffering of these changes of the urinary activity. But after the treatment, 3 months later, there was a very good improvement. Because of I have to be honest, because of the kind of patients we have some issues with doing uroflowmetries in this first part of the follow-up. We're trying to do some changes in the system, in the features of the selection and the follow-up, to include the uroflowmetry. But clinically, patients are very happy with the treatment. We did a very simple comparative between the minimal invasive surgical therapies, UroLift, Rezum, Aquablation, and HIFU. In our experience, HIFU is a very simple system. The timing of catheterization is similar to Rezum and Aquablation, but for us that are using the system as an outpatient procedure, is that we don't have bleedings, we don't have risk of damaging any other structure, and it's very well controlled because of the visual or the ultrasound guided system. So we are very happy with our outcomes, and the amount of tissue ablated is excellent. You can see that originally Rezum and Aquablation didn't talk about the possibility of bleeding, but depending on the amount of tissue destroyed, there are several documents, several articles that are considering that there are intense or severe bleedings, mainly with Aquablation, that need a routinary cauterization of the procedure. With HIFU, we don't have that situation. We're very happy. We usually do the procedures around 9, 10 o'clock in the morning, and 2-3 hours later, patients can go home without any issue. So it's a good possibility, a good option, considering the rest of the technologies. And thank you.
Carlos, can you hear us?
Yes.
Okay. What's your upper limit of prostate volume? So clearly you've got to get the 4 centimeter focal length to the anterior TZ. And I just wondered what the upper limit was of volume. I would have estimated around 60 cc's.
Sorry, it was not very clear to me. The sound is not very clear.
I don't know why this is getting feedback. I was going to ask about the upper limit of prostate volume. How big a prostate can you treat?
Okay, sorry. The sound is not very clear. We were including patients with around 50 cubic centimeters, but the limitation is the height. We have 4 centimeters as a normal height because of the system, but we have considered 4.5 centimeters as height. Strictly, we're talking maybe of around 60 cubic centimeters as a patient that can be treated with HIFU.
Thank you.
Thanks. Do you do twice? Do you do twice if the prostate volume is larger, or say it's 50 to 60 cc? Would you recommend doing it, say, after few weeks or months and do a second stage? Because this is kind of a minimal invasive. So if the patient prefers, say, a 70 cc prostate, would you do it twice?
Well, we're trying to select patients to do only one session, but it's possible to do 2 sessions in those cases that the prostate is very, very big. The advantage is that HIFU is very limited in the zone that we treat, and we're not causing any damage to rectum or to the neurovascular bundles. Strictly, in my center, we're trying to select patients to do only one session. But yes, it's possible to have a couple of sessions in case of bigger prostates. Pero alpha blockers para antes, después. Well, more than alpha blockers, just relaxant. We used 5 alpha blockers. No, the dutasteride is the one that we use more, and I have more confidence in the possibility of reducing the volume. Strictly, it's very, very occasional when we try to do a treatment of HIFU in BPH, and we use some kind of hormone blockage to reduce the volume. Our experience with prostate cancer, when we had very, very enlarged prostates, was using a combination of a total and maximal hormone blockage to reduce the volume. But strictly with BPH, we haven't used it. Maybe a couple months with dutasteride, and it was enough to have a good reduction. Okay. Thank you. Thank you, and goodbye.
Great. Well, it's a true pleasure to be here. Dubai deserves a focal therapy program. Success for me would be coming back at the end of the year and seeing one of you start a really successful focal therapy program, attracting patients from all over the region and indeed all over the world to come and be treated in a really high quality program with great imaging, great biopsy, great treatment, and great follow-up, which can be done at a distance. I see focal therapy as the measure, in fact my last slide, of a high-quality prostate cancer program because it creates exacting requirements of you and your colleagues and because you have to individualize care. And I see it as complementary to active surveillance on the one hand, or whole gland therapy with multiple sequential treatments for very high-risk patients with multifocal, high-stage, high-grade disease that are going to need more than one treatment. And, you know, if we're going to go to the effort of risk stratifying with precision, so we're going to do MRI, very careful biopsies, it makes sense to stratify the risk so that we can allocate treatments to different individuals and not say to everybody, you can have all treatments and leave the man to decide. So, you know, low-risk patients probably don't need treatment. High-risk patients need lots of treatment. But there are many patients in the future that will be able to have a minimally invasive treatment virtually without side effects. And I'll give you the data to support those statements. And really, it's just a new way of thinking. Historically, we identified men with prostate cancer. If that cancer was above a threshold of risk, they just got whole gland treatment. It was a linear process, a one-size-fits-all, in which we removed the prostate or irradiated the prostate, independent of location, of multiplicity, of grade, of stage. They all got the same. And today, it's really, you know, and this is an old scan. This is 2005. It just shows how long we've been imaging prostates. But you know, you can see the lesion there on the right, marked by it's sitting there at 9 o'clock on the axial view. The rest of the prostate is free of cancer. It makes utter sense to try and direct your treatment to the cancer plus a margin and preserve the key structures and preserve the healthy tissue, so that that man can have his cancer treated, but not have his quality of life compromised in any way. I mean, you can see this cancer from a scan that is over a decade old from across the room. And of course, if you target these lesions, you find cancer of appropriate cancer core length. This chap had 8 millimeters of Gleason 3+4, which amounts from a direct hit to this 0.4, 0.5 cc lesion that you can see there. And I think increasingly in the future, the whole management of prostate cancer is going to be about these lesions. If you do an MRI and you don't see anything, the likelihood is that they have no disease or have very, very microfocal Gleason 3+3. Lesions we are finding increasingly are associated typically with Gleason 3+4. And if you have a lesion, we were discussing this yesterday, you know, and the first time you see it, you just don't know how long it's been there. You have no idea about the natural history of this lesion that you can now see at 6 o'clock on the axial view, a rather unusual place for a prostate cancer, because there shouldn't be any ducts there, but there are. This was a prostate cancer, again, a Gleason 3+4. So we don't know how long that lesion's been there, we don't know how quickly it's growing, but we are learning, and this is work published quite recently by our group, of the natural history of these lesions over time. And this is a 5-year study of surveillance of these lesions. The details of the study don't matter, but these graphs do matter because they show that if you have visible disease, it increases the risk of progression. So it changes Gleason 3+3 to Gleason 3+4. If you have visible 3+4, it behaves like Gleason 4+3. And so you can see in the green the highest progression rates were there of visible Gleason 3+4 compared to non-visible 3+4, which is in red. And you can see that visible 3+3, which is in blue, behaved very much like Gleason 3+4. And this is obvious. If you've got a lesion, there are at least 100 million cancer cells present. They have a much greater opportunity to proliferate. If you can see it on gadolinium, the cancer's built up a blood supply already, and so it's undergone genetic and phenotypic changes that are going to result in that cancer progressing. And so if you see a lesion, and you know it's going to grow, and this is the data that shows that that's the case, it makes sense to treat it as soon as you see it. The treatment, if you're going to treat it focally, will only get harder and more exacting because you will have to apply a greater margin if you wait with time. So the sense of waiting, which historically has been commonplace in terms of active surveillance, makes less sense if you've got a lesion. If you've got a lesion, you know it's going to progress, and you want to treat it at its smallest point so you can preserve as much prostate tissue as possible. And this is another individual. So this time with a right peripheral zone lesion. The light's quite bright in this room, so you can't see the low T2 signal on this slide, this picture nearest me, but I think probably you can just make out a thumbprint. But then you can see it very clearly on the ADC on the other side. And just to reassure you that we're keeping up to date, we can generate lesions in lots of ways. MRI is obviously the typical way, but this is a nice slide from an Australian group in men that had PSMA PET scans and MRIs, and you can see that different cancers expressed different phenotypic changes, so allowed them to be depicted by different imaging modalities. The biggest cancer was positive on PSMA PET and MRI, as you can see there. This cancer, slightly smaller, was PSMA positive but MRI negative. This cancer was PSMA negative, MRI positive, and you've got the smallest cancer there, which hadn't yet developed the phenotypic changes to allow it to be detected, so it was PSMA negative and MRI negative. So you can see how sophisticated we are in identifying a target that is amenable to treatment. And just to give you a glimpse into the future, and there's no reason any of you should know about this is carbon-13 hyperpolarized MRI, which is giving us an indication of the metabolic status of the tumor. So in other words, how the cancer generates energy to survive. And you can see along the bottom line that the phenotypic expression here is not anatomical cancer. We are defining the cancer by the way that it generates energy to survive. And so you can see that now there is a wealth of ways that we can identify where the lesion is. And so when you see an MRI and you see a patient such as this, and he's got, this time it's a left anterior cancer there that you can see, so what's it telling us? It's giving us an insight into the probability of progression. It's also giving us an insight into the underlying genetics of the cancer. Visible lesions, this is a very complicated slide, and all you have to know is that the colors on the visible are different from the colors on the invisible. And if you've got your glasses on and you look down the left, you can see that the visible cancers were in general much, much more aggressive than the invisible cancers. Many, many papers showing this. So if you can see the lesion,
you know that the gene expression of the cancer is going to be worse towards aggressivity, and the underlying Gleason score, or Gleason sum, which you can see along the left, is going to be worse. So you're getting already huge amounts of information just by doing the MRI scan on that individual. And for completeness, many of you will be aware, we've got Canadians in the audience, and this company was out of Toronto. This is the exact imaging. So they are claiming that they can see cancers using this microfocal ultrasound. So basically using high frequency ultrasound, and cancers again can be elicited as a result. They're planning a large trial, and we'll see whether or not that is the case. So you see, we're in this era now of lesion generation through our very sophisticated imaging modalities, which I suspect we'll be applying in sequence or in harmony to the patients that come up to us. So a focal therapy program needs really good imaging to start the story off. As you can see here, so when was this? This is now nearly 10 years old, 2013. So this is a review of much of the focal therapy programs that were around about 10 years ago. And again, the results were that clearly it's possible, it's being done by expert centers. There are no systematic multi-center studies going forward, and it suggested a kind of pathway for the future, which I think we've adopted. In the last 9 years, a huge growth in data. So we saw one of the earlier slides that the 30 or 40,000 patients have been treated now. That there are at least 9,000 patients in the public domain that have been reported in various studies. We always want more data, and we're continuing to address that. So what is focal therapy? It's an approach, or heuristic, that aims to reduce the margins around which we apply to the cancer. And that's something we've done in kidney cancer, it's something we've done in penile cancer, and it's something that general surgeons have done in other cancers. So through imaging, we can apply much tighter margins and get away with it. Without imaging, when all we could do was feel the tumor, the margins had to be significantly greater. It is a system of care that individualizes the treatment. Every prostate is different, every cancer is different, every patient is different, and every focal treatment you do is individualized to that patient. You cannot say the same about robotic radical prostatectomy. Very often, it is exactly the same procedure that's done irrespective of many of the underlying features of the cancer. We're doing this not to improve the efficacy of care, we're doing this to enhance the survivability of cancer. So in other words, so that the years that you spend after your cure of cancer, you don't pay the cost through incontinence and through sexual dysfunction. And I've alluded to this already. We've seen a huge move of reducing margins around tumors and not seeing an increase in recurrence rates. So the move from mastectomy to lumpectomy, now 70 to 80% of women can get a lumpectomy, is kind of just another example of that. And finally, there are a few urologists in the audience. Urologists have always innovated. We used to take stones out by doing a big cut and then going down onto the ureter with and plucking out the stone. Now we do it without making any cuts. And so there's a huge history of reducing the harms of treatment by working with technologists and engineers to improve care. This is no different. So let's just pause for a minute and just see a case, just see how this plays out in a young man, a particularly young man with a positive family history, who's kind of very busy in his life of running lots of kind of enterprises, recently married, no children, so fertility was an issue for him, and clearly he saved sperm beforehand and froze it, but had a PSA of 3.3, which I think everybody would agree in a 43-year-old needs investigating. So here you can see, this is the base of his prostate. So on the picture near me, you can see the bladder above the prostate, which shows that we're right deep in the prostate. You can see a slight abnormality on the T2 in the left anterior horn of the prostate with the arrow. But you can see it really clearly from across the room, even if you're not a radiologist, on the T1 gadolinium sequence, so after the injection of contrast. And again, you can see that very, very clearly. There's clearly an abnormality. This could only be two things, cancer or some focal inflammation, probably of a granulomatous nature. To summarize his, and we have this on all the MRI reports, he had a Likert or PIRADS 4 out of 5. The diffusion lesion wasn't very strong, which brought the PIRADS number down a bit. But you can see there that the high probability of being cancer, and he underwent biopsies. And the biopsy A was to the left anterior horn of the prostate, and you can see that there were 3 cores sent to that, and that showed cancer of 1 millimeters, 2 millimeters, and 3 millimeters cancer core length, 3 plus 4, pattern 4 amounting to 20% overall, and the cores. Sorry, I haven't shown you the labels. On the other side of the prostate was, I think, B, and C was the remainder of the left peripheral zone on the left-hand side. So he underwent focal treatment to that area. So he underwent HIFU. This is my letter of the 15th of March 2019, writing to his doctor. The prostate took energy very nicely. So we were seeing the changes that Carlos showed us, so that the tissue responding to the energy very nicely. We were giving high energy exposure to the prostate, layering the treatment very tightly over the target, and trying to avoid all adjacent structures. And he was sent home a few hours later on some antibiotics, an anti-inflammatory, and a mild laxative. 3 days later, we take the catheter out and we do a post-treatment MRI, and you can see that the left side of the prostate, remember the prostate 3 days later is quite swollen, so the prostate size is exaggerated a little bit. But you can see where the arrow is, very, very dark tissue, non-perfused tissue. This is the coagulative necrosis that resulted from exposure to HIFU, killing the tissue. No blood supply to it at all. And you could see the rectum's quite full. He clearly wasn't taking his laxatives, but you can see the rectal mucosa beautifully preserved. There's blood supply to the neurovascular bundle on the left. There's blood supply to the neurovascular bundle on the right. Looking at it from a coronal view, so over the patient now, you can see that whole left area of the prostate completely covered with a little bit of margin into the levator, just to the left lateral component of the prostate. Doesn't cause any side effects and allows you to generate a nice margin around the tumor. So you can, through planning, I wouldn't start with a T3A tumor. This wasn't a T3A tumor, but I like to get a nice margin around a tumor, particularly if it's of higher stage. When we met 6 months later, his PSA had gone from 3.3 to 0.4, and the prostate cancer had healed. Sorry, this will be 12 months later. We tend to do the first late post-treatment MRI 12 months out, because by that time all the healing has occurred, and this is the way the prostate's going to look for the rest of his life. At least you hope this is the way the prostate's going to look for the rest of his life. And it shrinks right down. The left-hand side of the prostate has shrunk right down. It's gone from about, this was never a big prostate, so it's gone from about 10 mils on the left down to about 4 mils on the left. Again, showing what does happen if you treat this tissue. We treated most of the left lobe in this small prostate, and that's all scar tissue now. No abnormality on the diffusion scan, no abnormality on the T1 gadolinium scan. So you have what's an asymmetrical prostate, and you can see the rectum moving up into the space that is generated by the scarring of the left-hand side of the prostate. This obviously causes no symptoms at all, and just another view of how the prostate looks. Seminal vesicles look fine. This man, I think as I tell you now, his voiding is completely unaffected. Total continence. He's a very keen sportsman. The IPSS, when you treat focally for cancer, improves a bit, not as much as the BPH IPSS, which went from 21 to 11 from memory. That you tend to get about a 4 to 5 point reduction in IPSS if you measure it. This man ejaculates normal erectile function without medication, thinking about a child, another child now, and at present we're just monitoring his prostate, largely just making sure, because he's so young, that he doesn't develop another cancer on the other side. That's the main role of the MRIs now. Now that he's formed a scar tissue and hasn't recurred there, I'm very, very comfortable about the left-hand side of the prostate. I'll pause there for a minute and just see if there's any questions or anybody wants to challenge me on anything that has been said so far. Good question. So in the first year, I tend to do it every 3 months, so you find out what the natural variability is. So it's a calibration period. It takes between 6 months and 9 months to hit the nadir, largely because of the inflammatory process, usually by a year that you're there. And then thereafter, it's an MRI once a year, PSA every 6 months. And they can do their MRI where they live. They send me the images. In fact, that's what I was doing just now. And we get them reported. And it can be managed. They can be completely managed remotely on the other side of the world. And get their MRIs locally, as long as you know that the quality of the MRI is going to be okay. So, yeah, this patient is doing a semen analysis, so wants to see if he can father a child naturally, and so I'm going to send him to a fertility expert. The semen will be different. It tends to be lighter, more fluid. They say that the semen is clearer, so obviously it changes consistency, but there should be plenty of sperm there. So, we can use a lot of technologies to selectively ablate tissue. They all have to obey the laws of physics, sadly. But you can use, as you know, cryotherapy, extremes of temperature, very cold, very hot, high voltage current. Radiotherapy, you can use very, very high dose, which will ablate tissue. Radiotherapists don't like using radiotherapy at that high dose because they're worried about missing. But it can be, you can use radiotherapy in an ablative manner. Laser light has been used. We've tried a trial of toxic direct injection. It didn't work very well because the toxin went down the ducts, so you'd inject it into the prostate and it would shoot down the ducts. And of course, there are many cancer-selective treatments that are in pilot or phase 1, phase 2, and these usually involve nanoparticles and some form of initiation. I can hear my microphone changing. So who's eligible for focal therapy? As I've hopefully illustrated by now, it all really starts with the MRI. Somebody with a high PSA with me goes straight to MRI. I see them with the MRI. There's no point in me seeing them without the MRI because there's no conversation. I have to talk to them about their holidays. With the MRI, you can start to have a discussion about what's needed next. Reassurance if the MRI is negative, possibly a biopsy, possibly monitoring of the lesion, and a biopsy if the lesion progresses, which it will do. It's just a matter of time. I want to treat clinically significant prostate cancer. I want to confer some benefit to that individual. So these days, it's a lesion that is Gleason 3+4 at least. I need to be able to apply a margin around the... I think I'm too high. I've just dropped that a little bit. Is that better? Yeah. And many of the cases I've just shown you are lesions sitting away from all the key structures. So you remember the guy with the lesion in the right peripheral zone? Perfect candidate for focal treatment. The chap with the lesion in the left anterior prostate on the ADC map? Perfect candidate for focal treatment. So, can I get a margin around it, at least 5 millimeters, without damaging anything? And then obviously, you want a patient that's motivated. I've yet to meet a patient that doesn't want to be continent, so they all want to be continent. And clearly, this is a very good treatment for men who want to try and preserve erectile function. And we're doing a lot of work now in men who are starting to lose their erections on Cialis or Viagra, and it doesn't take much to knock them. And we're coming up with focal therapy plans so that we can maintain erections in these older men who may be diabetic, for instance, who are just starting to lose their erections. And as always, we want the patient to be fully consented, aware of the uncertainties, I'll talk about those, and aware of the salvage strategies. So what we would do if things didn't go as expected. And there is no treatment in prostate cancer that works in 100% of men. Focal therapy is no different, but we just need to be aware of the opportunities should the patient need extra care. And this really summarizes our approach from a kind of academic perspective and a philosophical perspective on focal therapy for the last decade and a half. And we started out top left, and now we're kind of bottom right as you look at the, and this is just, learning, working within the bounds of acceptability, working within the bounds of the law and ethics of what was possible then and what is possible now. And of course, before MRI, we had to treat anatomically because we couldn't see the cancer. We knew the cancer was on the right-hand side because we were doing extensive biopsies, 5mm template biopsies. Thank God we've stopped that. And we would treat half the prostate. As we started to be able to see the cancer, we could direct the treatments to the cancer, and the treatments were not anatomical. They were defined by where the cancer was. And you can see we go from anatomical to a treatment defined entirely by the location and morphology of the cancer. Then, as we got confident, we started to create a threshold above which or below which we didn't treat, and above which we did, in the same way that we do with active surveillance. So if a man comes to you with low-risk disease, most people in the world would say, we don't think you need treatment. We will watch this carefully with PSA and MRI and maybe biopsies in the future. So we made exactly the same decision, not at the patient level, but at the prostate level. And in the old days, when we insisted that patients could have no disease anywhere else in the prostate, it's quite hard to recruit to that because most people have got a little bit of Gleason 3+3. But in the same way that we don't treat Gleason 3+3 in active surveillance, we started not treating it in focal therapy. So I'm very, very happy. And in fact, all our trials, all our early trials, had a maximum of 3mm of Gleason 3+3, below which we were happy to observe, had to be non-visible, by the way, above which we then treated. And so you get into this bottom line here, where you're treating the risk, and you're trying to de-risk the patient from progression. And you do that by directing your treatment at the cancer that poses most risk, but you don't treat the cancers that don't pose risk. Now, in the future, we might be deriving risk through genetic profiling, through eliciting a phenotype from various imaging. We know, I think, now that MRI PSMA PET positive tumors are probably more aggressive than MRI PSMA negative tumors. So we're learning, and this is something we've learned this year. So we're learning constantly about how to define these cancers. And then down there on the far side on the bottom, patients ask, is there anything I can do after a focal therapy to reduce the chances of me developing a second cancer? And they want to know about exercise, diet. They want to know about pills and potions. And I think that's going to be something for the future. So trials to look at secondary prevention strategies. So once we treat an individual, what can we do to reduce the chance of that individual developing a second cancer in the future and requiring more treatment? But that's the kind of research question that all cancer patients ask, and prostate cancer patients are no different. So this is the kind of profile of patients that we treated 12 years ago, actually more than that, because this was published in 2010, so the patients were treated in the 3 to 4 years before that. So you can see that the majority were Gleason 3+4, quite a lot of 4+3s, and 10% of Gleason 3+3s. Now we hardly treat. I can't remember when I last treated a Gleason 3+3. And this patient was in this trial, but you've already met him, and those of you with a good radiological memory, Alex showed this case, who had a hemiablation. Back to my earlier slide, top left, what we used to do in the first study before MRI. This is an anatomical treatment that resulted in that lobe going down to virtually nothing, 2 to 3 mils of scar tissue with the urethra preserved just to the side of it. And this was the first result that study generated. Remember, this was a hemiablation study in men with Gleason 3+4, plus a third of men with 4+3, and that 90% of men achieved pad-free, leak-free continence, erections, and were free of cancer at 12 months. So that was the bomb that landed in 2010 when this paper was first published, that we could treat patients for prostate cancer and not impact on their genitourinary function. And that caused quite a stir. I got some very angry letters from people like Patrick Walsh, and he was very critical of us I haven't got that slide, saying that we were fooling the public and patients in the way that we reported the results. But I think he's calmed down a bit now, which is good. This was a subsequent study in which we were treating not anatomically, we were treating around the cancer, and the important thing here is that continence beautifully preserved, both definitions, all men continent. 95% of men kept erection sufficient for penetration. 95% were free of disease in this short, highly selective study. Again, in this study, this is the second study now, 84% of men achieved the trifecta of pad-free, leak-free, good erections, and free of disease. And this has become pretty standard now. Most people reporting are getting results such as this. That there is extraordinary uniformity in the outputs that you get if you start a focal therapy program. There will be few surprises. You will be delighted at how delighted your patients are with the treatment because they have it all done in a day and they're out functioning normally. I treated the patients on Friday before I came here on a Saturday. They're all going to have their catheters out this morning in a couple of hours, and I'll start getting messages from them that they're peeing and have gone for a walk in the park, etc. So just looking at sexual function. So we looked at this very closely. We're now looking at things like ejaculatory function, orgasmic function, penile length. So we're going to look at much more detail, and we believe that things like penile length are preserved, which obviously they're not on hormones and they're not with surgery, and increasingly that's important for patients. But just to say that the impact of focal therapy, amazingly, on sexual function is minimal and can barely be measured with the tools that we've got. There's a slight dip immediately due to inflammation and just the effect of being in hospital, but that goes back to baseline very, very quickly, irrespective of how you measure. You do have to tell patients, and I do tell patients, that we are very liberal in the use of medication. So we have a very low threshold for starting tadalafil at 5 milligrams once a day to support their return to erectile function. Whether it makes any difference or not, but patients quite like having that crutch to help them get back into normal sexual activity. This is not HIFU, but I'm just showing it to you because it's a randomized study, all right? And it was a randomized study because this involved a drug. I was the principal investigator of it. We published it about 5 or 6 years ago. It's not available, this treatment, in most jurisdictions, certainly not available in the UK, and it never went to phase 3 in the US. So I'm not interested in the intervention. I'm just interested in the randomized trial to show side effects. And this compared focal therapy against active surveillance in a randomized manner. So the individuals were identical in every respect, or as identical as you can make them. And then we measured side effects of, as you saw, a hemiablation versus active surveillance, basically doing nothing. And you can see there is no difference. Focal therapy is identical to active surveillance, doing nothing, in terms of functional status in a randomized setting, which is multi-center, which is incredibly powerful. So you've got a treatment here that you can do that feels like active surveillance to the patients in terms of function. And just to remind you, this is surgery now, Memorial Sloan Kettering. They show that between 20 and 30% of patients manage to get their erection back, so 70 to 80% don't, after surgery in a really top center in New York, and importantly, it hasn't improved over 10 years. It's exactly the same. Despite drugs, despite robots, despite better technique, their patients are still, in 70 to 80% of occasions, not getting their erections back. This is the alternative that your patients face. And again, back to the randomized trial, all right? So and randomized trials are useful because the patients are the same. And so you can see here that in the intervention, there was a slight increase in the mild side effects, as you'd expect. We were putting needles into the prostate. But really importantly, there was no difference in serious side effects. So this, the chances of getting a serious side effect was just as likely in an active surveillance cohort as it was in a focal therapy cohort. The death happened in the focal therapy cohort a long time after the focal therapy, and he had a heart attack climbing Mont Blanc. They got him down, but he didn't make it, very sadly. So that's the story behind that. So what about failure? So you can see that we can administer treatment very successfully. We can preserve function. We can do it with very, very few side effects in a randomized setting, which is multi-center. What about, if things don't go as planned? And patients have to be told, this isn't magic. We can get you free of disease and continent in 85% of patients, as I've shared for you from 2 studies. Some patients will need a second treatment. Some patients will need to move on to whole gland treatment. And I consent 85% of patients will just need 1 treatment over a 5 to 10 year period. 10% of patients will need a second treatment, and 5% of patients will need some other form of treatment in the future, surgery, radiotherapy, or hormones. But what have we learned about trying to reduce residual or recurrent disease? So I think the important thing is that there is no intrinsic resistance to HIFU. There is no carbon-based life form that can survive 80 degrees for 3 seconds, or 60 degrees for 3 seconds for that matter. What you have is energy passing through a prostate differently in every human being. And that's where the skill comes in. That's where the human being has to integrate and work with the technology, which you can see there, and the patient in front of you that is different from the previous patient and yesterday's patients, and you work together. And they say that the best combination is artificial intelligence and a human being, and the best combination here is a machine with a human being driving it, with lots of computer assistance to kind of help you and make your life easier. And I liken it to kind of flying an Airbus. I've never flown an Airbus, but if you look at the pilots, they're there, they're relaxed, but they're watching everything, just checking everything, that everything's okay. And if something happens that they weren't expecting, they switch off the computer and they intervene. And that's what the HIFU is like. And obviously the pilot lands the plane and takes it off, and that's exactly the same as HIFU. The positioning of the probe, the moving of the probe, and the removal of the probe is done by a human being, not by a computer. So understanding that and working with it and developing the skill is something that's very important, and actually gives one great pleasure and great satisfaction to be able to do it well. This is not a switch on, walk away. This is a switch on and work with energy to achieve your goal. And it's a very, very satisfying process. So what can we do to reduce the risk of the patient failing? Well, it's all about case selection. The focal therapy is all about case selection. 80 to 90% of the challenge is case selection. Driving the machine, we can teach you to do that. We can work with you. We can sit on your shoulder. That's the easy bit. Case selection is and choosing cases that are easy to do in the first case. So small prostates with lesions that you can reach easily, that you can overlap, and that you can apply a margin to, that are free of calcification. The sound doesn't go through bricks, and so if you see calcification when you're doing the ultrasound and biopsies, not a candidate for focal therapy. There aren't many patients actually that have calcification in the way. Obviously reducing the movement of the prostate. If you've got a big guy and the prostate's swinging and you're treating something that you think is static, you're going to miss. And so you ask the anesthetist to paralyze the patient. And then the beauty about this treatment is that you're constantly augmenting the plan. As the prostate swells, you add a few more cases. You think you want to treat a bit more there, you add a few more cases. So completely flexible for you, the operator. And what we've learned in the last few years is that compared to the old days when we used to work very much to plan, we're now overlapping the energy and creating lots of redundancy of energy in and around the cancer and getting much, much, much better ablation rates and getting post-treatment MRIs like the one I showed. Edge of field failure is largely about underestimating the volume of the cancer. All imaging underestimates the volume of the cancer in all organs. That's why we cut a margin around melanoma or brain cancer. It's not particular to the prostate. It's a feature of all cancers. And if you don't apply an appropriate margin and treat that margin correctly, you will increase the likelihood of getting a failure at the edge of the field, which you can normally deal with through retreatment, but you want to try and avoid it if possible. These in-field and edge-of-field failures will occur early, typically within 1 to 2 years, but we're getting much, much, much better at reducing the risk. And one way that we are reducing the risk is through better planning and using fusion software, and in this case to treat a cancer which is the bit in red, and you can see the margin in white. There's a secondary tumor. So this is a focal therapy to 2 tumors that were sitting pretty close to each other. And we're treating the left peripheral zone and the left anterior horn, left peripheral zone in yellow, left anterior horn in red. And you can see the margins generated by the software, which you can tell the software how much margin you want. And you can see the margins overlapping. So you're coming up to a treatment plan that is defined by the fusion software. And this is transformative. We used to have to do this in our brain. Now we can have it all laid out in front of us. We've now got an airport to land the Airbus in, whereas before you had to kind of create one in your mind. Out-of-field recurrence is clearly an issue for focal therapy. It's a huge research opportunity as well. Remember, in active surveillance, the patient hasn't had a high-risk cancer, otherwise they wouldn't be on active surveillance. In focal therapy, you are preserving tissue in a patient who has had a high-risk cancer. And we don't know the likelihood of that individual developing a second cancer in the future. What you can offer them, though, is extraordinary close surveillance with PSA and MRI. And so if another cancer does develop, and the risk is small, in kidney it's 5%, in breast it's about 5%, I suspect in prostate it's very similar. You will pick it up very early and you will be able to offer them another treatment if necessary. But there's a lot of interest at the moment on the genetics of out-of-field recurrence. And we're learning a lot about how prostate cancers are born because we're doing focal therapy. Because we've got this in vivo human model in an individual who's already had a cancer that is worthy of treatment. And we're seeing what changes occur on the other side. And we can do the genetics not only of the patient, but of the cancer, should a cancer develop. And so we're seeing a cancer be born, not in many patients. And you can imagine just how much value that is in research terms going forward. So I'll skip that. And I'll pause a second, because I know this is a long lecture, just to give everybody a breather. Does anybody have any questions on what I've said so far? Of course, yes. I've just been told to repeat the question if I get a question. Yeah. 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 Alex makes a really good point about being clearer about calcification. You don't have to be scared of calcification. So if you see calcification in a prostate when you do a biopsy, you don't have to go, oh, he's not eligible for focal therapy. you have to look where that calcification is and decide whether it's going to get in the way of your beam. As urologists in the audience and online know, most calcification in the prostate occurs between the transition zone and peripheral zone of the prostate. That is hardly ever an issue because most cancers that you're going to treat are in the peripheral zone. In fact, it might even help because it creates a kind of a mirror into which the energy is directed and is concentrated and maximized within the peripheral zone. So when you see calcification, you just have to ask yourself, is it on the side that the cancer is on? And is it going to get in the way of the beam that I am sending from posterior to anterior, so from across the rectum? And very few bits of calcification get in the way, unless you are treating an anterior prostate cancer, because then obviously you have calcification sometimes around the urethra and sometimes in that zone between PZ and TZ. There are some calcifications that don't matter, and if you're not getting an echo-pore area behind the calcium, you can often get the beam across it. But I wouldn't start with those cases. That's kind of something that you develop as a sense of the density below which you can still get a beam across. But Alex makes an excellent point. You don't have to be scared of calcification, you just have to assess it. Yeah. 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 Fine, yeah. Yeah. So this is a question about prostate volume and eligibility. If you can reach the cancer with your 4 or 3 centimeter focal length probe, and you can reach all peripheral zone cancers with a 4 and 3 centimeter probe, it doesn't matter how big the prostate is. It can be 200 cc's. You're not treating the anterior component. And in a sense, you're ignoring the prostate volume. You're concentrating on where is the cancer and can I reach it. So prostate volume isn't a contraindication. In fact, I haven't mentioned prostate volume to date because the inclusion criteria is can I get at the lesion and can I apply a margin around it? I don't care how big the prostate is. I don't care if they've had a previous holmium laser prostatectomy or a TURP or virtually anything else. So I'm asking the questions about the cancer. So I'm very, very happy to treat 100 cc prostate as long as the target lesion is within the peripheral zone and can be reached, or in the anterior horn and can be reached. With big prostates, you just got to be a little bit careful. You don't want to start with big prostates because the anatomical orientation in a big prostate is lost on ultrasound. So all the boundaries of the prostate will sit outside your window, and you can easily get lost in the prostate. And so I would start your first 10 cases with prostates that are 40 cc's or less, so that your anatomical fiducials are there to help you guide treatment. And you'll just know where the sphincter is, you'll know where the urethra is, you'll know where the capsule is, you'll know where everything is, and you'll be much more comfortable. Once you're confident, and with fusion, you can take on huge prostates because you don't later on need that anatomical knowledge. The other thing about big prostates is that they are much more likely to have longer retention periods afterwards, and so you have to be a little bit careful about managing them afterwards. I get the catheter out and get them onto intermittent self-catheterization sooner rather than later, so they're not wearing a catheter for too long. But size, even though they have big prostates in Texas, doesn't matter really in terms of focal therapy. It's the cancer, it's the lesion that defines whether or not you can have treatment. So, I get asked these questions from patients. So, how does focal therapy compare to prostatectomy in oncological terms? And as we don't have a randomized trial, I don't think we'll ever have a randomized trial, actually, honestly. And I say that as a trialist. I probably randomized more patients than most people in urology. So I've spent most of my life randomizing patients. I think this is a very, very difficult randomization. To say to a man on the toss of a coin, we're going to randomize you to surgery or focal treatment is very, very difficult. And we've done pilots that have shown that 25% of men refuse the allocation to the surgery arm if they are randomized to that, making nonsense of the randomization. So I don't think we're ever going to see a randomized trial. And you know, what happens, doctor, if focal therapy doesn't work? Well, I told you, but I'll show you a paper that that hopefully will give you some reassurance. So this is as close as you can get to a randomized trial without doing a randomized trial. So it's a propensity-matched analysis of patients having prostatectomy versus focal treatment. Not just HIFU. The majority of the patients had HIFU in this cohort. A few patients had cryotherapy, but the focal therapy patients were taken from a database of 761 patients, and the laparoscopic prostatectomy patients were taken from a database of 572 patients, and each patient was matched. So if a patient went into the analysis, they had to be matched by all the criteria that you can see there. This isn't perfect. It's as good as you can get. And you can only match by the criteria that you have. So in the end, we ended up with equal numbers of patients that were then subjected to the analysis. And this is as close as you can get to it. So before matching, you can see there's difference. So men having prostatectomy were more likely to have Gleason 3+3, interestingly, than men having focal treatment. Yeah, 40% versus 27%. This is pre-matching, right? It's just interesting to observe. Once you match, identical, you know, because you've got rid of, so you've matched by all the criteria. So again, going to that Gleason 3+3, it's 38% versus 37%. No significant difference between the two. A completely identical cohort on all the features that you can match. Obviously, the features that you can't match, that you don't know about, you can't match on. And that's why we randomize. But this gets pretty close. And this was published recently. It took a while to get published, kept getting rejected. I wonder why. And this is why, I think, because it showed if you extract patients from two legitimate, validated databases, you match for key confounders at 3 years, at 5 years, and at 7 years. There is no difference in failure-free survival, success rates, of focal therapy versus surgery. Focal therapy is in blue, and focal therapy is slightly better than surgery, but the differences were not significant. Yeah? So I'm not going to allude that one was better than the other. I think we can say here that there was no significant difference in failure-free survival that chose to have focal therapy versus men that chose to have surgery. And that's pretty much as good as you're going to get with 7-year outcome. There is no better study other than a randomized study, and we're not going to get that. So what about, and a lot of surgeons worry about this, they worry about operating on people after focal treatment. We're learning a lot more about this. This is very, very different to operating on people after radiotherapy, operating on people after cryotherapy, operating on people after whole gland HIFU. Focal therapy, remember, treats just a part of the prostate. Most of the dissection is normal. Bladder, neck, contralateral side, apex should be a completely normal dissection. You'll just have a little bit of scar tissue on the side that was treated. These are the patients. They're pretty kind of normal cohort. You can glance through this. So, you know, the majority of the patients were T2A, indicating that these were unifocal, this is radiological T2A, unifocal MRI lesions. Most patients are Gleason 3+4, as you can see there. By far the majority of the patients of this very small group had high-intensity focused ultrasound beforehand. And this is the post-operative surgical outcome. At the bottom, very, very few complications. This is safe treatment. The majority of the patients kept their grades. There was no grade escalation, 61% 3+4. And again, the majority of the patients remained PT2. Obviously, these are progressors. And here, continence preserved, so all the top ones are continence. And here in the pink that goes up, these are men with good erectile function prior to the salvage prostatectomy. The majority of those patients, amazingly, kept their erectile function. If you were losing your erections beforehand, you didn't do so well. And there's the freedom from progression line that you can see in these patients that have salvage surgery following focal therapy. So in summary, RAFT represent the first registered prospective study. We showed that surgery after focal treatment was safe. We showed that most men had a return of continence at 12 months. Men with good baseline function had a very high probability of keeping it, which is amazing, given that they had 2 treatments, and 80% freedom from biochemical failure at 12 months, which is not too different from the primary series, which is really quite extraordinary. How are we doing for time? Yep, okay to go, okay. Well, I'll pause there, so, and just ask see if there are any questions on... Yes, in the study I'm about to present, there were 3 cases of metastatic disease, one of whom died. I've not presented that yet. That's the next slide. So you can read my mind. Yeah. So that question was about metastatic disease. And of course, patients with cancer are at risk of metastatic disease. That's what we're trying to prevent. There's no suggestion from any of these series that the risk of metastatic disease is increased by exposure to focal treatment. Yeah.
In guideline-based practice where HIFU would be lower on
Yes. So
medical legal.
it takes a long time. This is a question about guidelines and about whether you're practicing within a guideline framework. It takes a long time for evidence to get absorbed by guidelines. And the example I tend to use is MRI. And most of us have been using MRI a long time. We'd been using it for over 10 years before NICE approved MRI in April of 2019 after 11 randomized trials, all showing the same. So it takes a long time for things to get into guidelines. If we waited for everything to get into guidelines, we wouldn't progress. All right? My job is to change guidelines. My job is to do studies, to generate, that's my job, is to generate new data so that tomorrow's guidelines are different from yesterday's guidelines. Because if guidelines don't change, we don't progress. So nothing I do is within guidelines.
This is very different for practitioners in this region because
Yeah.
you tend to not want to do something outside the guidelines because
Yeah.
you won't be able to save yourself.
Okay. So this is a really important question about working within a framework of care where this type of treatment is authorized, credentialed, and all the guidelines that we use currently, so NICE and EAU, and recognize that focal therapy is an important component. They recognize that the data is relatively immature. I would argue with that. But they say that it's fine as long as it's done with appropriate consent. I've been through the consenting issues, and also done within an approved registry, so that you have a commitment to report your cases and share them and discuss them. And of course we do that. And this next paper is proof of that. But you would expect that with any surgical procedure. And I would be worried if we didn't do that. So that, if you do your focal treatment with HIFU with the support of your colleagues, it's very hard to work without the support of your colleagues, and within that framework of committing to share data, coming to meetings like this so we can all constantly improve, that is perfectly acceptable and within the current guidelines. So this was published very, very recently. This is the outcome of focal therapy using high-intensity focused ultrasound in well over 1,000 men and up to 15 years. Not many men made it to 15 years. It caused a huge stir when it was published in European urology. It caused, and And the thing that caused the stir was this. So this is a medical journalist. He's a doctor, probably one of the best-known medical journalists in the UK. He writes in the Times, on TV a lot, and he wrote an article based on the paper saying, well, based on what I've read, if I was ever diagnosed with prostate cancer, I would want HIFU. And I think a lot of patients, contacted us, and it's interesting. And in the article, which you can download, there's a firewall behind the Times, so you have to kind of pay. It's not like the Guardian. You'll see that he goes through the data and tells you why. And he's essentially giving my lecture, but obviously with a lay reader in mind. And let's go through the data and see if you agree with Dr. Mark Porter. So this is the patient profile of the patients that were treated, this 1,370 something patients. So at age 66, it's a reasonably young cohort of people that are going. These aren't 75-year-olds. I mean, there is the odd 75-year-old, but the mean age was 66, which is similar to most radical prostatectomy series, actually. 20% of men had a PSA between 10 and 20. So this is not a very low-risk group. Most men had a PSA of less than 10. There's no question. But 1 in 5 had a PSA between 10 and 20. Now that could have just represented prostate volume, but I don't think it did in many cases. The mean volume here of the prostate was 36 mils, so much smaller than the BPH series we heard earlier, which means that the PSA densities were quite high, which obviously carries risk. 16% of the patients had Gleason 4+3, so nearly 1 in 5 patients had Gleason 4+3. I think we would all agree this is moderate to high risk disease. A few patients had higher risk than that. Most were T2. It's very hard to know what staging means these days. I think in this context it's radiological T2. You can see an abnormality on one side of the prostate. And by far the majority of these were T2A, which sits just below it. By D'Amico risk, which is not a perfect risk stratification, but one that you can apply to other cohorts, so we can get a sense of the risk, by far the majority here were intermediate risk. And I think it's just worth noting, just once and for all, because sometimes we're criticized, HIFU's just for patients who don't need treatment. I hear that once a month. Only 1.5% of the cohort had had a type of prostate cancer that we might define as very low risk. 1.5. So 98.5 of the patients were treated with clinically significant cancer. And in most patients, the intervention was a quadrant ablation. So I've talked about the various types of focal therapy in that slide with, this is treating a tumor with a margin. And in a small prostate, and remember these were small prostates, that tends to mean that you treat about a quarter of the prostate. So left posterior, right posterior, left anterior, or right anterior. And of course, as in all case series, most of the patients were treated recently. So this is a system of care that is gaining momentum, and the recruitment is year on year just gets more and more and more. Once you start a program, you're overwhelmed with inquiries of people who want to have treatment. And this would be a typical patient, treated within, PSA of 7.6, a Likert score showing a T3A lesion on the right, Gleason 3+4, pattern 4 equals 10%, 6 millimeter maximum cancer core length. This would be a typical patient from this cohort, and the kind of patient that would normally have surgery or radiotherapy depending on their age and comorbidity, to whom you can offer this treatment. And the results, surprise, surprise, very, very similar to the results that we published 10 years ago. And this is for intermediate risk disease, right? So the results 10 years ago included low risk men. This is intermediate risk disease. So freedom from failure, 83% at 5 years in this group. And we used two different definitions. One included death, and another one just included prostate cancer specific ones. But this is failure-free survival that I'm showing you here, which does include death, etc. And very few side effects, as you can see here. As you can now see here. So serious side effects in less than 1% of the patients operated upon. And those who like time curves, you can see there's quite a distinction between the very, very few low-risk patients who really don't have the capacity to metastasize or spread versus Gleason 3+3 and Gleason 4+3 patients who look very similar in how they behave. Now, there's a few bits of data that are important that are in the appendix. You have to click on the appendix for the study. If you do HIFU and there is a recurrence, and obviously there were quite a few learning curves, this is a multi-center practice, you need to be committed to retreating patients within field until you can get that rate low. So 200 of the 1,300 patients had a second treatment. Only 39 patients of the 1,300 patients went to radical prostatectomy. 53 patients went to radical radiotherapy. So often, if patients do fail, and some patients will, they're often quite old by the time that happens, if they develop out-of-field failure or the PSA starts rising. So radiotherapy or hormones might be the way to go. 7-year ADT-free survival was 92%. And to your question, 3 patients developed metastases of the 1,300 patients. Interestingly, all had very low PSAs. I mean, one had a PSA of 1 point something. All had T3A disease, so non-secretors. I mean, we can spot these patients now with MRI, as long as they get an MRI. And these patients must have presented with an abnormal DRE, got an MRI, and then were treated, because none of them had an abnormal PSA. So low PSAs are a risk factor. I know you all know that, but it's increasingly becoming apparent. Low PSA patients just didn't get treated before. So I'm near the end now. So data is accumulating. This is a multi-center, multi-user contemporary experience. HIFU is very safe. And like active surveillance, if you're trying to preserve tissue, this is a system of care, and the patients need to know that there's a small chance that they may need more treatment in the future. But actually, they might, as a result, get many, many years, sometimes a decade, free of the complications that are associated with whole gland treatments. And we can be very, very sure now that the freedom from failure is in the order of 83–85% of patients at 5 years for a multi-center study, and this includes expert centers and new centers. So, what have we got? Focal therapy has emerged as a new class of therapy that I think commands legitimacy. Huge amounts of patient acceptance. It's very easy to recruit to a focal therapy study, as long as you don't randomize. Patients love it, and they'll do anything to try and get it. It has kind of positive attributes in terms of harm reduction, health economic, etc. Focal therapy has forced the precision that we now require from MRI and biopsy. So if you do focal therapy, you will ask great questions of your radiologist, and you will ask great questions of your pathologist that you're not forced to ask when you're treating in a whole gland manner. Many of the treatments to date, such as cryotherapy, have been around for 100 years. The treatments now that we've got, and the refinement of the treatments that we've got, have been designed deliberately for the focal therapy task. The planning, the way that software is run, and it's much, much, much easier to become a focal therapist today than it was 15 years ago, when it certainly wasn't in the guidelines. So what do you need to start? You need exceptional imaging. You need a true partnership with radiology. Your radiologist becomes your best friends. You need near perfect risk stratification. If you're getting upgrading from your biopsies to your radical prostatectomies, that is the amount of error in your biopsies. All right? So And you've got to get that upgrading down to a minimum, because that's all error. And if you have and some people had upgrading of 50%. They published that, it was a while ago. So they get it wrong half the time. So they tell the patient, you've got Gleason 3+3. They are wrong half the time. You've got to really reduce your upgrading error, but you do that through MRI and targeted biopsies. That's not difficult, as long as your MRI quality is good and you are diligent in terms of how you biopsy your patients. You have to become expert at managing energy sources, but we'll teach you to do that. We will do this with you. We'll get you to the right place. We know how to create experts from non-experts. And you need to be committed to long-term follow-up of these patients, as we've said before. And lastly, I think I said this right at the beginning, I think focal therapy is the key determinant of a high-quality prostate cancer care unit, for all the reasons I've said, and I won't repeat them. Thank you very much. So with PSMA PET now, you can manage high PSAs quite safely. If somebody comes to you with a high PSA in the pre-PSMA PET era, you didn't know whether they had metastasis, just hadn't declared. If their PSMA PET is negative, I'm quite happy to attribute the PSA to chronic inflammation or high secretion. So PSMA PET has made it possible to do. So I don't know the answer to your question. It's probably in the 30s or 40s, I think. And I've got many patients with, as you have, who run a high PSA. With MRI and PSMA PET, you don't have to biopsy them as often as we used to. But many of these patients have been biopsied 6 times, and they come to you saying, please don't biopsy me a 7th time. So it's difficult, and it causes huge anxiety in the GPs and their family, and it's hard to manage, but PSMA PET is the answer. Yes, good question. Surprise, surprise, they've both been physicians, they've both been doctors, and they refused a biopsy, but they had a PIRADS 5 lesion that was growing. Both refused a biopsy, and I've done it. So, I think, we remove a kidney based on a 95% probability of a cancer being present. With a PIRADS 5 lesion, you can be 95% sure that it's cancer. Occasionally, I have patients from abroad, and they're busy businessmen, tight schedules, and they don't want to come for a biopsy, let it settle, and come back for a treatment. And so what I have done, rightly or wrongly, is they have a very high probability. I'll do a biopsy just before the treatment, send it off for frozen, confirm, and then we've got the tissue, and then I'll treat. Who wants to come up and play with the machine?
If you can come up,
Yeah.
please. While you take us through, the cameras are going to tighten in so
Yeah.
that the people viewing online. So if you can take us through maybe kind of a 10-minute orientation session, and if you need an extra pair of hands.
So we're in the axial at the moment, the one that's moving. Yeah. It's much easier in a human being, right, than a box. There's a little bit of reverberation. So in the midline, you can see an echo pore area. That's the urethra, yeah? And you can see a very round prostate. And we're going into the bladder now. I'm just going in. It's not letting me in any further, so I'll just go freehand. And I'm going into the bladder. You can see a lesion with a bright rim around it, just in the left inferolateral aspect to the urethra, as I just pull back. And that's obviously, the phantom has created that. And as we go in, prostate's getting smaller. Seminal vesicles, which here are bright, appear now. and then through the bladder neck and into the bladder. There's the seminal vesicles, a little bit kind of cephalad, and then we go into the bladder. So I'll come out now. So we're in the bladder, and this you can see in patients. We're just coming out. Bladder neck is closing. Seminal vesicles are disappearing. You can see the prostate there. I'm moving to the to the patient's left, to the patient's right, and just on the way out, there is another lesion somewhere in this gland. I'm just pushing the probe up to the prostate to try and get a slightly better picture. Can't seem to see it now. So there's the lesion. That's the peripheral zone cancer. Cancers don't look like that in real life. They just look echo-poor. They don't have a bright rim. And as they come out, you can't really see very much because of the reverberations that are getting. You don't get these repeated curvy linear things on the, there's the other cancer. So in the right anterior horn. Sorry.
Is there a preference over the view, or it is just individual? So axial versus.
Okay, so we can switch now to. Maybe somebody could do this for me. If you press on that. Yeah. So we're now in the sagittal view, in the midline. You can see the urethra. So going from bottom up, we've got the first kind of interface is condom. Actually, within the condom, you can see bubbles, which shouldn't be there. They're the things that are moving around. And obviously, in a case, we'd have everything running, and the bubbles would be cleared for you by the machine. Then beyond the condom is lubricant, and then rectal mucosa would be the next interface. And then in a human being, you would see serosa. You can just make out the difference between mucosa and serosa, which here you can't. You're getting a reverberation of that first interface in this model, which is confusing things a bit. And then typically in the human, the next interface you would see would be fat, perirectal fat. And the radical prostatectomist will know all these areas. And then beyond the fat, you will see the prostate capsule, and then obviously the peripheral zone, and then you go anterior. But all those anatomical structures are very visible to you. So we're in the midline, so I'll just go to the left. Again, there's quite a lot of artifact. You're seeing the bubbles within the condom, within the balloon, are causing an echo-poor area. So in the anterior is one of the cancers. So that bright thing up there is a cancer. Again, it would not be bright in real life. It would be dark. And the seminal vesicles would be dark in real life. Yeah. And there's the urethra there. But so this is roughly how it looks. And this is the ease with which you can kind of manipulate the probe to have a look at the prostate. Remember, you know, in a big prostate, you wouldn't have all these anatomical cues telling you where you are. Yeah.
Because of the compression.
That's right. Yeah. Do you want to try it? So. So what you can do is you can twist it. So should we move to axial? So it's probably easier.
I would like to look here rather than
there.
Yeah.
See,
it's more easier.
Why don't you look at there? That's right. Yeah.
Go into the bladder, maybe.
Yeah. So in fact, you're going to have. Yeah, that's right. So you have to take the weight of the if you've got that. Yeah. There's a little bit of delay.
Yeah.
Just a tiny bit of delay. So you just work slowly and let
Would that be always in real time as well?
Yeah. But you just move slowly and it catches up. The processing time is much quicker than it used to be. And there you see your images are better than mine. Beautiful. You can see the prostate very clearly. Urethra. You're following the urethra down, and as you push the probe in,
the apex, basically.
So then you take the probe out, come out slowly, and the prostate gets smaller and smaller, and you can normally see urethra. And you often can treat right down to sphincter, and sometimes beyond sphincter, in those prostates that, as you know, when you're doing a radical prostatectomy, the left and right lobes often, like buttocks, and the sphincter sits in between them. But you can see the rectal mucosa, the perirectal fat, very nicely, and then there's a gap, which should really be there, between the perirectal fat and the prostate. And there's seminal vesicles, look a little bit bright.
Can we activate the
Yes.
sage?
So we're now going to move to the sagittal view.
Started treating.
Yeah. And so if you come out a little bit, that's it. And you've got the whole prostate in view there. And now you can go left and right to find, there's your left lateral lobe of the prostate. You're coming back towards the midline. Your urethra will be visible in just a second. There it is, beautiful. And obviously with the catheter in place, the urethra is very visible. And then you can go to the right lateral aspect of the prostate. That's right. Good.
I think people doing their patients self-biopsies, meaning they doing rather than a radiologist or a sonologist, would be finding it easier to kind of manipulate.
I think we can credential you as an expert. Thank you. Yeah.
The system set up. If there aren't any other questions, lunch is ready.
Great.
But we're going to leave the system set up, so if you have any questions, or if you'd like to come and get a hands-on demo for yourself while other people are eating, I believe the food is ready, so if you'd like to go ahead and step out. To our audience that's watching us online, we will thank them for their attention, spare them from having to look at us enjoy all this amazing food provided by the Malia Desert Palm that we're about to enjoy. So we thank everyone that's been online dealing with some of these sound issues that we had early on. We hope that you learned something new today. The Can-Am Scientific team, which has been in contact with you, is there 24/7 for follow-up post the conference, but we thank everyone that's been online as we sign off. Thank you to Dr. Garcia and to Professor Mark Emberton for such a great session today. So thank you very much. Hope those of you that are online have a great afternoon.